Hello. Thank you, Dr. Domchek, for such an insightful presentation. Now we will move on to our first live Q&A session. And I'd like to invite Drs. Bardia, Domchek, McArthur, and Klemp to join us as panelists for this Q&A session. What we thought we would do is we would start out with a couple of cases that have been prepared. And while we go through the cases, we'll monitor the chat box. And as questions accumulate, we will take those questions. So we'll start out with our first case. So this is just a map showing us where all the attendees are this morning. And you see we have attendees from all across. And thank you for your active participation. Case number one, we have a 48-year-old lady with germline PALB2 mutation with a T2N0 ERPR positive HER2 negative breast cancer, oncotype score of 32. She was treated with adjuvant TC and now an adjuvant tamoxifen. She had BCT at the time of diagnosis, but a year later is having second thoughts about choice of surgery given the PALB2 mutation. How would you counsel this patient? Her only family history is a paternal aunt with breast cancer at age 55. So Dr. Domchek, that's for you.
Great, thank you so much. It is worth stating that we really have limited data to date on contralateral breast cancer risk related to PALB2 mutations or other mutations. As mentioned with the Bowie et al. Abstract from San Antonio this year, when they looked jointly at non-BRCA1 and 2 mutations, they didn't see a contralateral breast cancer risk that was that different. However, mostly that's going to be CHEK2 and ATM, and PALB2 is sort of the closest thing we have to, if you will, BRCA3. Having said that, when I'm counseling PALB2 mutation carriers, I kind of take the default setting that their contralateral risk cannot be higher than BRCA2 mutation carriers. And if you actually look at the data related to contralateral breast cancer risk in BRCA2, it depends when the first cancer was diagnosed, whether it was ER positive disease, and also the current age. So you may easily look at this case and actually find that the risk of developing a second primary cancer in the contralateral breast is not as high as you might think it is. So it's completely reasonable to do breast conserving therapy in this case. Even for BRCA1 and 2 mutation carriers, it's a reasonable decision. And I would say that kind of, if you will, knee-jerk response that BRCA1 and 2 mutation carriers have a 50% chance of developing a second primary cancer is not true when you get to, a 48-year-old, even if this was BRCA2, a 48-year-old ER positive disease, because we're really talking about residual lifetime risk. So I would say to her that we're not sure what the contralateral risk is, but that it could be, as maybe as high as 30%, but unlikely to be that high. And it's certainly reasonable that she did not do that. So I don't know if others have any comments, but we certainly need more data in this area.
Would you offer her MRI for surveillance if she chose to stick with her original surgery?
Yes, certainly. So we would, it's a great point. And sorry, I didn't mention that. We would certainly do MRI alternating with mammogram in this situation. And our biggest problem with BRCA1 and 2 and probably 2 mutation carriers is, if you will, when to stop doing breast MRIs. In general, I continue doing them as long as people don't have any significant competing medical problems, but it's not always easy to figure out when that is. Another issue that comes up is the risk of ovarian cancer. BRCA1 and 2 clearly have an increased risk of ovarian cancer. PALB2 does seem to have an increased risk of ovarian cancer, but it's not nearly the same as BRCA1 and BRCA2. And sort of our best estimates at this time are that the lifetime risk of ovarian cancer may be in the 3 to 5% range. That's not a range that we generally recommend immediate oophorectomy. So at this point, for us, it's more of a discussion. If there is a family history of ovarian cancer, that's going to change the equation and push us more towards considering oophorectomy. But I do strongly counsel that unless there's a particular reason why you're thinking of doing it, that premenopausal oophorectomy in PALB2 mutation carriers should likely be avoided, and that you really should be thinking about it. If you're going to do it, one should consider it postmenopausally, again, unless there's a significant history of ovarian cancer or it's part of sort of breast cancer therapy.
So this lady sticks with her original choice of a BCT, unfortunately develops osseous metastatic disease 2 years later while on adjuvant tamoxifen, and is started on first-line therapy with a CDK4/6 inhibitor, and an AI, undergoes BSO at the time of diagnosis of metastatic disease to be able to take an AI. But in a year has progressive osseous disease, has 2 new liver lesions and pulmonary nodules. Tumor testing does not show PIK3CA mutation. So at this juncture, what would be your treatment recommendation? PARP inhibitor, fulvestrant plus everolimus, single agent platinum, single agent taxane. Does the presence of mutation influence any of these choices?
So just to take a step back about the current FDA approvals, there's 4 tumor types that have FDA approvals for PARP inhibitors. Breast, it's for germline BRCA1 and 2 mutations only. For pancreatic cancer, germline BRCA1 and 2 mutation carriers only. Ovarian cancer has pretty wide approvals, all ovarian cancer, but the devil's in the details of how much benefit each group gets. And prostate cancer is complicated because of the study designs where they kind of lumped in BRCA1 and 2 and other genes all into a cohort. And so the approval is based on all of that, even though the bulk of the responses are seen with BRCA1, BRCA2, and PALB2. So currently in breast cancer, we don't have approval, FDA approval for the use of PARP inhibitors for PALB2 mutations. But based on Nadine Tung's work and others, PALB2 does seem to be a gene where you see responses germline and in germline mutations and even somatic mutations. So I do think PARP inhibitors are reasonable. There's multiple ongoing studies, TBCRC048, a trial called Lodestar using rucaparib, and that would be my first preference is to do this on study, because I'm not sure, how FDA insurance approval is. It's not clear whether you get insurance approval or not. The question of platinum is very interesting. It does seem also based on, again, not large series, but there does seem to be evidence that PALB2 mutation-associated cancers respond in a similar way to BRCA1 and 2 associated cancers with high response to platinum therapy. And whether or not, and Dr. Sharma certainly can speak more to this, whether or not a run-in of platinum and then a maintenance of PARP inhibitor should be a strategy that we use is open for debate. That's what's being done in ovarian cancer, BRCA1 and 2 associated ovarian cancer, and BRCA1 and 2 associated pancreatic cancer, which is a platinum run-in followed by maintenance PARP inhibitor. We don't have, a lot of data on that specific to BRCA1 and 2 mutation carriers, but it is a really interesting technique. So for instance, here I do think that a PARP inhibitor alone could be considered. However, depending on how sick a patient is, you can consider platinum therapy, particularly if you can't get PARP inhibitor approval. A reminder that in the PARP inhibitor studies with monotherapy, the time to response was no difference in PARP inhibitor versus non-platinum-based chemotherapy. So people do tend to have reasonable responses. We don't have for taxanes, we don't have great data for PALB2 specifically, but for BRCA1 and 2, if I'm choosing between platinum and taxanes, I would choose platinum. And fulvestrant plus everolimus is always there in the background for when you use it. But personally, I would probably be a little bit biased towards a PARP inhibitor. Curious to hear what everyone else thinks, though.
Dr. McArthur, Bardia, do you have additional thoughts?
Yeah, I would probably pick none of the above, quite frankly. I often, the PALB2 mutation aside, I often harken back to, the EFFECT study, which showed that switching from a non-steroidal to a steroidal aromatase inhibitor was equivalent to switching to fulvestrant. And so I would potentially consider exemestane with everolimus as per the Bolero-2 study. And although there were no patients on Bolero-2 who had prior exposure to CDK inhibitors, there have been retrospective studies, including a study at Oregon OHSU did a retrospective study demonstrating that patients who had received a prior CDK inhibitor did as well with the Bolero-2 regimen as those who hadn't. So I think that would be a reasonable fifth option here.
Kind of optimizing endocrine therapy to with multiple choices.
Exactly.
So one of the questions on the chat is around the use of PARP inhibitors in those with CHEK2 or ATM germline mutations. Is this something that there's data on? Are you using it?
I feel pretty strongly that the data is negative, meaning that in TBC or C048, we didn't see any responses in ATM or CHEK2 germline mutation carriers. When you look at the prostate cancer data, you similarly find it doesn't look so good. And in prostate, again, the way that the trial was designed is that BRCA1 and 2, ATM and CHEK2 were in one cohort. And so the approval was given for all of them. But actually, when you dig deeper, you really don't see much benefit for PARP inhibitors. So I think the ATM CHEK2 story, I absolutely would not give it off study. There are now ATR inhibitor studies going on for ATM mutation carriers. One such study is called Planet. And I think that we really need to get better choices, but I would not give CHEK2 and ATM mutation carriers PARP inhibitors off study. And my preference for PALB2 is to do it on study. But I recognize that that can sometimes be challenging. And again, I don't know that insurance would cover a PARP inhibitor even in this setting.
So a somewhat related question came up about the risk of gadolinium over time for women with mutation that are getting MRIs for a long period of time. Is there any concern?
So the FDA is monitoring this situation carefully, and just, take a step back. The concern is that gadolinium is, a heavy metal, and that a minute amount of gadolinium is retained after MRIs. The feeling is that this is all about risk and benefit. So for BRCA1 and 2 and PALB2 mutation carriers, it is definitely felt that the benefit outweighs the risk. There is at this point, any known negative consequence to human health, apart from those individuals who, for instance, are on dialysis, for which, the NSF, the skin disease has been associated with that. If you Google gadolinium toxicity, you will find a lot of things out there in the lay press. And I think that it's incumbent upon us not to ignore that and to be careful and to monitor it. But right now, there is, we are not aware of any kind of negative impact. So I do counsel patients about it. And as women get older, I do check creatinines, but even in younger women, our institution doesn't require creatinine prior to the administration of gadolinium unless there's a known other health problems.
Thank you. This is a great discussion. We'll move on to another case. So this is a 42-year-old with clinical T2 node positive grade 3 TNBC, receives neoadjuvant Taxol carbo-pembro followed by AC pembro on a clinical trial, undergoes mastectomy, has a 1.1 centimeter residual disease in the breast, but all the nodes are negative. In this setting, would you recommend adjuvant capecitabine? Does inclusion of checkpoint blockade and carboplatin in neoadjuvant regimen influence your recommendation for capecitabine? And what about adjuvant pembrolizumab? Dr. McArthur or Bardia, do you want to take this one?
Sure, I can start. It's a bit of a data-free zone. So we know from the CREATE-X trial that patients who have residual disease, those who received capecitabine did better as compared to placebo, and there was an improvement in disease-free survival. But CREATE-X did not include patients who were getting immunotherapy, who were getting the Keynote 5-2 regimen. So it's a bit of a data-free zone, but we do know that patients who have residual disease are at higher risk of recurrence. And so to potentially reduce the risk of recurrence, it's reasonable to consider Xeloda. Now, as far as the question of adjuvant pembrolizumab is concerned, it's not approved yet, so I would not do it outside of a clinical trial. If there's a clinical trial that provides access to immunotherapy, by all means, it's reasonable to consider that. This patient did have some response, whether it was a chemo or immunotherapy, it's tough to know, but it could definitely be the immunotherapy that resulted in response. If there's a trial, I would feel comfortable with immunotherapy, but outside of trial, would recommend adjuvant Xeloda.
And it's interesting because there's no data that's really forthcoming to inform this decision tree, actually. So as you know, on Keynote 522, adjuvant capecitabine was not permitted. So patients who were randomized to receive neoadjuvant pembrolizumab continued on with pembrolizumab, but did not receive capecitabine. And in the SWOG 14-18 study, which is the study of 1 year of pembrolizumab versus not for residual triple negative breast cancer in the adjuvant setting, patients must have completed their chemotherapy regimen, including capecitabine, before being enrolled on study. So there are no studies, to my knowledge, looking at combination strategies. However, David Page at Providence in Portland did present a study looking at capecitabine versus paclitaxel in the first or second line metastatic setting together with pembrolizumab, and demonstrated tremendous synergy with capecitabine and pembrolizumab in that study. So it is possible that there is synergy to be harnessed with that combination, but we just won't have randomized data. This is a very timely question, of course, because the Keynote 522 regimen is going to the ODAC next week on Tuesday, looking for FDA approval for this regimen. And this is the first time that a regimen has gone to the FDA based on a neoadjuvant design, but also asking for adjuvant approval as well. So it'll be interesting to see how the FDA treats that data.
So while we're on this question, I'm going to talk about a few questions that came up during Dr. Bardier's presentation on the chat box. Of course, the first one was, what are your thoughts about incorporating platinum in the neoadjuvant regimen? And does the presence of BRCA mutation impact that decision?
Yes, I can address this, but would be curious to hear from other panel members as well. So to answer the question about platinum, is a risk-benefit ratio. We do know that the addition of platinum can increase the rate of pathological complete response. So if I have a young patient with lymph node positive disease, I would certainly consider platinum for that patient. And the reason I mention young patient is because of the toxicity. The downside to platinum is the increased risk of toxicity, including myelosuppression. So if I feel comfortable that this is a patient who would be able to manage the toxicity and the risk-benefit ratio is favorable, I would certainly consider platinum. The traditional option would be AC Taxol platinum, but we also have data from Dr. Sharma demonstrating that Taxotere plus platinum 6 cycles is associated with a PCR rate that's pretty close to ACT. So that is another potential regimen to consider. Now, as far as BRCA mutation is concerned, we have data from a couple of studies demonstrating that if you add platinum to anthracyclines, you can improve the PCR rate, but you cannot essentially switch the platinum with anthracycline or with Taxol. That question was specifically looked at in the INFORM trial, where the team looked at platinum versus anthracycline, and essentially the outcomes were pretty much the same in terms of the pathological complete response. So my decision personally is guided by the baseline risk of recurrence, as well as the likelihood that the patient would tolerate the regimen.
So this patient is quite informed and also brings up the question of ctDNA testing given residual disease, and should that be done? Is that something that, how do you address this question in clinic?
Well, I'm going to punt and say that we put them on a trial, so that we're. I think it's very difficult. I've only looked on study right now, and I wanted to bring up one thing about the BRCA 1 and 2 issues. If a patient is off study, again, there's a pretty high rate of pathologic complete response to AC. So I tend to sort of use, what was mentioned before, the baseline risk, but also how individuals are clinically responding. If they seem to be responding very, very well, I may not add the platinum to the taxane as well. But again, I didn't really answer the ctDNA question because we would try to put them on a study. Is anyone using it clinically on the panel? Just curious.
Not yet. I mean, we don't know the best way to apply ctDNA testing. I think it's a really exciting technology, and I anticipate that we will be using it clinically sometime in the future. But do you test at one time point? What's the time point? Is it trends over time? How do you actually apply this technology? And that's where I think I agree with you, Dr. Domchek, that clinical trial to sort of rigorously evaluate how best to use these technologies is really needed. And with the platinum question, I actually use a lot of platinums, to be honest. You know, the CLGB and the GPAR-6 trial showing PCR benefits, but no statistically significant correlation with long-term cure rates. But after the brightness trial, which showed benefit regardless of BRCA mutation status, I did start using it a lot more, and I use it up front with weekly paclitaxel. Actually before AC, I typically start with the taxane week 1 and then fold in the carboplatin the week 2 to see how they tolerate it. I can generally only get about 9 weeks of platinum in before the bone marrow starts to fail and neutropenia risk increases. But that's been my strategy before making decisions about an anthracycline.
So as you can see, we all use it differently or don't use it, and just because there is the data can be interpreted in a lot of different ways, and till we have adjuvant data, that this is all we have to go by on. Okay, so we'll move on to the next case. It's a 52-year-old with HER2 positive ERPR negative de novo metastatic breast cancer, bone disease, receives first line THP followed by HP for 18 months with really good disease control, subsequently has progression in bones, treatment switched to trastuzumab plus lapatinib, has progression in liver in 9 months, then receives TDM1 for 15 months, followed by progression with new pulmonary disease, and MRI brain without brain mets. Which one of the following options would make the most sense for this patient? Trastuzumab deruxtecan, CAPE trastuzumab tucatinib, CAPE lapatinib, or the newly approved margetuximab plus chemotherapy. This is becoming a routine situation in clinic where we have more options than what we know to do with, which is, I guess, a good problem to have.
Yes, I can jump in since I just gave that talk, but as you point out, Dr. Sharma, I mean, there's a wealth of options, which is such a great and exciting situation to be in, to have options. Originally, when the HER2 Climb and the Destiny data came out, I sort of had this algorithmic approach thinking that I would keep the HER2 Climb regimen in my back pocket until brain metastases occurred and use trastuzumab deruxtecan up front. However, I'm finding that in real world practice, patients really have strong feelings about which regimen they want to pursue. Both are approved in this post 3-line setting, so either one could be considered. I find that some of my young patients, for example, who have hair after TDM1 prefer the tucatinib regimen, which is not associated with alopecia, whereas the trastuzumab deruxtecan regimen is associated with alopecia, for example. So I find that the toxicity actually is informing these decisions, but it's great to have so many terrific options.
Yeah, I would add that it depends also how symptomatic your individual is from pulmonary disease, because that actually can just complicate the deruxtecan issues. You know, if someone's already symptomatic from a pulmonary standpoint, and then you're giving them a drug that can potentially cause pulmonary toxicity, it could just make it a little bit harder. So, so that sometimes does factor in, not in a definitive way, but if they have brain mets, we've been definitely more likely to give them the tucatinib regimen, but without brain metastasis, then a little bit it depends exactly on what was mentioned, the potential toxicity and how that may manifest in an individual.
So the patient was started on option number 2, had a nice PR, and which has been quite durable. Now she's inquiring that can the capecitabine part of this regimen be stopped with just the 2 HER2 targeted drugs? That's something that you all have thought about in your practices, or does it come up?
I think one of the biggest challenges is what to do when HER2 positive patients do well for long periods of time, and when do you ever stop anything? I have a woman who's been on lapatinib and an AI now for 9 years, right? And is she, dare we use the C word, for cured? I have someone else who's been on trastuzumab alone for 8 years. This is only 9 months, but we do have those challenges, right? So personally, in this situation, I would tell her that I don't know, but if she's really not tolerating the capecitabine well and wants to stop it, well, we've certainly done that before.
Yeah, yes, you would let the toxicity guide that decision. So we'll quickly do the last case. It's a 52-year-old with T2N0 TNBC treated with neoadjuvant ACT, mastectomy, 8 millimeter residual disease and negative sentinel lymph nodes. 18 months later, develops liver disease. She's a germline BRCA2 carrier. PD-L1 testing shows a CPS greater than 10%. So it's a situation where you have both the germline BRCA mutation and PD-L1 positivity. And so the questions kind of revolve around which do you choose first, and what chemo regimen do you combine immunotherapy with, and does the mutation status have an impact on your choice of chemotherapy partner? How do you sequence platinum and PARP?
So I can just make a quick comment on, we published data Mediola, which was olaparib and durvalumab, limited number of patients, 34 patients with BRCA1 and 2 mutations, and Javelin, there's Javelin, one of the Javelin studies has closed that also included BRCA1 and 2 mutation carriers with a combination of avelumab and talazoparib. Again, in the limited Mediola study, what we found was the response rate was quite similar with the combination as it was to PARP inhibitor alone. Now, whether, so the question then becomes, whether there's really synergy. There's some preclinical data that there should be synergy, and that Mediola had a 4-week run-in before the durvalumab was added. So, but long story short, I don't think we have, compelling data about this. For a while there, we could only get immune therapy approved in the first line. So, if somebody was PD-L1 positive, you would tend to do that because that was the way that you could get drug. So recognizing that we don't have a clear answer to this question, except that we know that in the immune therapy studies, mutation carrier status didn't predict response. It was all about the PD-L1 testing. And again, you guys can fine tune that statement for certain. But here, I might choose two. I might choose pembrolizumab plus carbo-gem, and then actually, based on sort of the PANC literature and the ovarian literature, use that as a switch maintenance where you get the carbo-gem in and then potentially switch to olaparib. Now, do we have specifically olaparib pembro data? No, but we have all these other data from both Javelin and Mediola that would be a safe reason. And you can only give so much carbo-gem, as we all know. You can only give so much carbo. So that would be, so I would probably not choose a taxane in this setting. But I would also, there are data both for immune therapy and PARP inhibitors that giving things first line result in better outcomes. So that's kind of why I'd go to switching into one.
So I think we're running out of time. This was a great discussion. We will now move into a 15-minute break. So please refill your drinks and snacks. And as a reminder, please complete the CME evaluation to obtain your credits. This information can be found on the right-hand side of the screen, as well as on the front desk in the virtual lobby. I want to thank all the panelists for a great discussion and their insightful comments.
Thank you.